Okay. Good afternoon and welcome to today's webinar, co-hosted with the U.S. Department of Health and Human Services Office of the Assistant Secretary for Preparedness and Response, or ASPR. I'm Brian Nyquist, President and CEO of the National Infusion Center Association and Executive Director of the Infusion Access Foundation, and I will be your host today. I'm honored to be joined by Dr. Meredith Chuk, lead of the COVID-19 Therapeutics Administration team at HHS/ASPR, Gina Smith, Disaster Medical Assistance Team under HHS and ASPR, presently assigned to the COVID-19 Therapeutics Administration team, Woody Baum, CEO of OI Infusion, Shannon Fisher, Director of Clinical Services with MPP Infusion Centers, Gary Puckrin, President of National Minority Quality Forum, and Sarah Schreiber, also assigned to the COVID Therapeutics Administration team at HHS/ASPR. Thank you for taking the time to join us today, panelists. We have an exciting webinar experience for you that will focus on the continued need for utilization of COVID-19 monoclonal antibodies, commonly referred to as mAbs. In this session, we will start by outlining the federal government's COVID-19 response and the obstacles that contributed to suboptimal uptake of mAbs. We will share success stories of 3 non-hospital pop-up models that quickly and efficiently operationalize mAbs while mitigating exposure risk among non-positive patient populations and frontline HCPs. We will outline the barriers associated with integrating mAbs and expanding the national access footprint for these infusion therapies. We'll share lessons learned from operationalizing these administration sites as well. And finally, we will look at data and the role of predictive analytics in understanding continued incidence of COVID-19 disease and demand for mAbs nationwide. At the end of the session, we will address your questions and share guidance with those interested in operationalizing mAbs. We are very excited to share these success stories with you, explore how common obstacles were overcome to integrate this temporary service offering for COVID-positive patients, and most importantly, we look forward to engaging in an interactive discussion with you. There's a lot of content to cover, and our goal is to provide a robust and interactive Q&A. So attendees will remain muted during the presentations. Please submit questions as they arise throughout the webinar by clicking on the Q&A button at the bottom of your Zoom window. Thank you all again for attending today's webinar. Now I'll hand it over to Dr. Chuk to kick us off with an overview of the federal government's COVID-19 response strategy. Dr. Chuk.
Great, thanks, Brian, and thanks for the opportunity. I'm really pleased to be here and looking forward to the discussion. Next slide. So I'll be very brief. I'm going to give a little bit of an overview of the monoclonal antibody program, talk about some of the administration methods and some of the successes and obstacles, and then end with ongoing and future efforts before we get to the rest of our panelists. Next slide. I'm just going to start with a summary of the available COVID-19 therapeutics. These are therapeutics that are either approved by FDA, authorized by FDA, or recommended in NIH clinical treatment guidelines. And as you can see here from the spectrum of COVID disease, from the no illness all the way up to ICU admission, we focus on the early symptomatic or the pre-hospital phase. The monoclonal antibodies are the only therapeutic in this space. And the reason that they were authorized was based upon their potential to keep high-risk patients out of the hospital. This is a really important and unique therapy. And we're excited to hear about how folks are implementing that. Next slide. So there are 3 monoclonal antibody products that have been authorized. And again, they were authorized based on their potential to keep high-risk patients from disease progression and therefore hospitalization. So not only an individual patient benefit, but also a societal benefit to decompress some of the hospital systems. HHS/ASPR has been in charge of the distribution of these therapies. And our goal is really to expand access to as many sites as possible so that as many of our high-risk patients can have the benefit from these therapies. Next slide. So there are a number of places where the monoclonal antibodies can be administered. They can really anywhere from a hospital to a home setting. Each of them have their pluses and minuses and challenges. Certainly hospital-based infusion centers, emergency departments have been a popular place for infusion, given the fact that you can link testing and treatment, which is an important part of the patient pathway that we'll talk about. Can be some alternative care sites with hospitals, ambulatory centers, which we'll hear much more about today, and some of the models that have been set up using infusion centers and pop-up infusion centers. Nursing homes, certainly skilled nursing facilities and nursing homes has been a very important location, as the residents are certainly generally in that high-risk category and are certainly affected by COVID disease. So bringing this therapeutic to that area is an important area. We've also seen mobile sites and home infusion as is also an appropriate location for providing these therapies. Next slide. So the challenges with the administration really from the beginning have been several. So there are challenges with both staffing and space, as we'll talk about and hear about in our examples, I'm sure. There had also been some challenges with some reimbursement strategies. There have been some challenges with data in terms of the evidence upon which these were authorized. I'm not going to go back to that first slide, but if you notice, there were some NIH treatment recommendations for the combination monoclonal antibody therapy, the bamlanivimab and etesevimab. So since the initial authorization, which were based on earlier phase clinical trials, there have been phase 3 clinical trials and more clinical data that has come out to the point where NIH and IDSA actually have recommended these therapies. So that's been a big benefit for provider education as well. One of the things that we've been hearing about is that sites are slowing down on their patient levels given the decrease in cases, which is certainly great, and as vaccines are going up. However, we know that the high-risk patients are still out there. We know that we're only reaching about 15 to 20% of the eligible high-risk patients with monoclonal antibodies. So it's really critical that even during this time that we don't see sites closing down, that we actually see new sites opening up, so we're really able to reach as many high-risk patients as possible. So instead of seeing vaccines and monoclonals as an either or, we really want to see them as an and. So they're both tools in our toolbox that we need to really use to their maximum. One of the best ways to do this is really to think about the patient journey and make sure that on each point of that journey, we have areas that we're able to complete that process. So it's pre-educating our high-risk patients to make sure that they know when they get sick, they should get early testing. Monoclonal antibodies patients are eligible within 10 days of symptom onset, but we know that earlier is better. So pre-educating high-risk patients to know that should they get sick, they should get tested early. Having them then contact their provider and then having the provider refer them to that infusion center. So again, many steps along the way, many steps that patients can get lost along the way. So we really need to make sure that in every community, each point of that patient referral pathway is complete. And then I will just simply end on the fact that there is some new federal efforts and some new funding that has been put into making sure that the monoclonal antibodies, that we have equitable access for all of our underserved communities as well, so that we're really able to put increased resources. And we're very excited to be hearing more about that over the next couple of weeks, so that we ensure that we are able to provide this therapy to our highest risk patients. So again, looking forward to the discussion. Thanks so much for the opportunity.
Thanks, Dr. Chuk. In the interest of time, I'll provide a brief overview of these three mAbs administration models. Then I'll hand it over to the panelists to share the biggest challenge they encountered with their specific model. We'll then dig into the audience's specific questions during Q&A, so please submit any questions you have for the panelists through the Q&A feature. All three models, excuse me, were stood up to be as lean as possible with the minimum core infrastructure and F&E required to minimize operating costs without compromising safety, consistency, or quality of care. None of the models utilized a pharmacy for preparation, so drug was prepared in a designated preparation area on open benchtop using aseptic technique and best practices per NICA's industry standards for outpatient infusion. The OI model involved partnership with a primary care group that took care of ordering and billing CMS, and this primary care group paid a flat fee payment based on operating costs to the infusion operator. This model leveraged new infrastructure and existing F&E to stand up a temporary administration site outside the PCP office for a direct referral stream. The administration site was overseen by an MD on site at the PCP office. Drug is prepared by RNs and administered by MAs in this model. This model was operationalized in 4 weeks with a max throughput of 6 patients per day using 3 chairs. The MPP model involved partnership with the Texas Department of Emergency Management, involving a flat fee payment based on operating costs to the infusion provider. This model leveraged existing infrastructure and F&E, dedicating 2 existing infusion sites for CMAB administration on the days that these sites were closed. And the space is decontaminated prior to treating any non-positive patients in that space. The infusion provider orders the drug through the state, but does not submit claims for CMS reimbursement. The administration site was overseen by an on-site nurse practitioner. Drug is prepared by NPs or RNs and administered by either an NP or an RN. This model was operationalized in 4 days with a max throughput of 50 patients per day across 2 sites using 5 chairs in each site. The third model involved pop-up tent infrastructure and existing and repurposed F&E. Drug was acquired through state allocation and direct ordering, but claims were not billed for reimbursement. The administration site is overseen by an on-site MD or nurse practitioner. Drug is prepared by either an RN or a PharmD and administered by an RN. And this model was operationalized in 2 days with a max throughput of 22 patients per 12-hour day using 8 chairs. So Woody, Gina, and Shannon, I'd like to give each of you the opportunity to prime the audience for our Q&A by sharing the biggest obstacle that you encountered with your model. Woody, we'll go ahead and start with you.
Yeah, so we, my name is Woody Baum. I'm the CEO of OI Infusion. We are the largest operator of infusion centers in the Northeast. And our model, there weren't a ton of obstacles to setting up that, setting up the infusion center. We had been looking at doing CMAB infusions and couldn't get comfortable with it because we didn't have the real estate and we're unsure about the reimbursement challenges. And so by partnering with a primary care group that had contracted directly with the state, we removed the obstacles to operationalizing. They had contracted with the state to acquire the drugs, had negotiated their own reimbursement scheme with the state. And all we had to do was do what we did best, which was set up, staff, and manage infusion centers. So it was very easy to get going. And then operationally, once we were started, the biggest challenge we faced, which was not unique to our model, but I think unique to CMABs, was the patient journey. How do we get patients to the center where they're touching multiple different entities in the process? It could be really confusing and intimidating. And we found that there was a lot of cancellations by patients because by the time they were scheduled to get their infusion, they had often canceled their treatment because they were feeling better. So there was a lot of non-compliance in the process, and just the complexity of getting this infusion made it reduced utilization. So that was our biggest operational challenge once we were up and running. And that's it, Brian.
Oh, I'm sorry, I was on mute. Thanks, Woody. Gina?
Hi. So we have the pop-up model. We were adjacent to a healthcare facility. It was a partnership that we had arranged with them before we went in. So our greatest challenge when we opened up our operation, we learned very quickly, was the message, getting the message out to the community and the providers that we were open for business and available for the infusions. We did not take appointments at our site. We did walk-ins, referrals from physicians, and we also had individuals that came in with their results, and we had a physician in our tent that was able to do an evaluation and screen them to see if they met the high-risk criteria and were eligible. So our biggest challenge when we identify it is the fact that once someone was tested, it was how to get them from the test to us. And that's why we did not do it by appointment and did it by walk-ins. So when individuals heard about it, they didn't have to go back and make an appointment to come in. We did see 22 on our highest volume day, but we did have the capability of seeing over 40 if we had the patients that came to the tent. So we did have the capability, but our challenge was getting the word out. When we have our wish list, we say that if we could have done the testing right there at the site, the rapid testing, we could have easily handled that volume of 40 a day. Thank you.
Thanks, Gina. Shannon?
Hi, thank you. So initially our challenge was trying to figure out what centers we would use. Since we have so many centers in Texas, we went with centers that were only open 1 to 2 days a week, and we had a challenge trying to figure out how we would treat COVID patients and also treat our existing biological patients. So we had to really figure out how to do that. Another challenge we had in the beginning was medication, acquiring medication. It was just very difficult. We partnered with several hospitals to try to get the medication, along with continued partnership with Texas State Health departments and the Amerisource Bergen's team for medication allotment, trying to get that. I would say one of our biggest challenges we had was the call volume that we were getting from patients as soon as they found out that we were doing these. Our call volume went up about 287% with patients just calling and asking, where can I get these? How do I get these? What's going on? So that was a very big challenge. And the challenge that we continue to have and continue to monitor is how to monitor our infection control, since we are seeing other patients in these centers. So really getting the staff up on board on infection control and how we need to clean these centers and take care of these centers, since we are treating COVID positive patients.
Thank you, Shannon. So one of the most common barriers infusion providers have described is the perception that COVID and demand for mAbs will be gone by the time they can operationalize an administration site. I'm excited to hand it over now to Gary Puckrin with the National Minority Quality Forum to share an important tool that may help us project and understand future demand. Gary?
Thank you so much, Brian. Appreciate the opportunity. So the National Minority Quality Forum, we are a research and education organization based here in Washington, D.C. We've been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year, covering about 72,000 conditions. Back in July, we started to work on predicting COVID events, new cases and deaths at the zip code level. There was a lot of good data coming out at the national level, but there really wasn't great data at the community level. And so we've built something, and we just actually releasing it this week. It's called the COVID Index, and you see the web address up there in the right-hand corner, and you're able right now to go in and use the index. Next slide. So we are projecting COVID events about 30 days before they occur. So you can actually go in, and by clicking on the map, you can pull up a zip code. And here we're looking at a zip code in Michigan, 48377. We give you both historic data going back to the beginning of the pandemic back in March, and then we're following it out for the next 30 days. And here you can see towards the right, those pale orange colors there, those are our predictions, and they get updated nightly. So it's a rolling predictions that we update nightly. Next slide. We worked with Nick about looking at federally qualified health centers because of the underutilization of the therapeutics in minority community. We were trying to understand where the infusion centers were in relationship to federally qualified health systems that we work with. There are about 17 across the country that we're working with right now. What you're looking at on the map is Watts Healthcare Corporation, and you can see that there are some infusion centers around the blue area is the office of that FQHC, and the red are the infusion centers. Actually, when you dial in a little bit closer, you see that these infusion centers are not all that close to these FQHCs, and that becomes important for minority community where transportation can become a problem. And this is really one of the more populated in terms of infusion center service areas. We've got many FQHCs that have no infusion center in their community, and there's really a great need because of the high levels of hospitalizations and mortality and the underuse of the therapeutics in minority community. Next slide. So we've got the first version out, and I just wanted to show you this quick version. We're looking at the same Watts clinic, but in the next iteration, it'll come out about a week. We're really pulling out the site so that the service area, so you can get a closer look at what's happening in the community. Next slide. We're also doing some scoring. So in the next iteration, we're going to actually provide a scorecard. We're going in and we're looking at both the county level as well as the zip code level and giving you a sense of where those hotspots are. Right now, if you go to the index, you'll see that California has probably got the highest level of new cases in the country. Next slide. And here we begin to show you that rank. Riverside County in California right now, these scoring is based on population size as well as new cases. And so we rank each of the counties, and we're doing the same thing with zip codes. And the whole idea is to get messages out to these communities and where the therapeutics can be applied to make sure that messages are getting out. Often in minority communities, certainly, no one is talking to them about using the therapeutics. Next slide. And just some more examples of looking at what's going on in California, giving you a little deeper dive on the map where the virus is right now having its greatest impact. Next slide. That's it. Thank you so much.
Great. Thank you, Gary. So we've received several questions throughout the webinar. We'll go ahead and transition to Q&A. So with vaccine rollout underway, the concern that mAbs will no longer be relevant and demanded has been reported as a barrier to uptake. Dr. Chuk, in your portion, you specifically mentioned how mAbs need to be utilized with vaccine. Would you share your thoughts on the role that mAbs will play in reactive treatment, including treatment of the SARS-CoV-2 variants?
Sure. So thanks, Brian. No, I think these therapeutics, I think will have a role for quite some time. Again, even with our current utilization rate, we're still only getting 15 to 20% of eligible high-risk patients. And as the larger portion of the population is vaccinated, that number will continue to go down. However, there will continue to be patients who either are not yet eligible for vaccination and meet a high-risk criteria, choose not to get vaccinated, or for whatever reason don't mount an adequate immune response, whether or not from underlying illness or whether concomitant medications that they're taking. And certainly there is concern about decreased efficacy with some of the variants, although certainly those are ongoing studies. But I think there is definitely will be a continued need, and this really should be an and proposition in terms of monoclonals and vaccines, and not an either or. So thanks for the question, and I hope that's one of the biggest takeaways going forward from this conference, for the need to continue this.
Thanks, Dr. Chuk. Go back to our panelists. In terms of your models, what are the biggest challenges that you are still encountering? At least we'll go through the same order. What do you want to chime in?
I guess, and it's not a problem with the model. It's just that we're not, reaching enough people, but patients are canceling their infusions. They're feeling better by the time they're scheduled, 1 to 2 days after testing, and they're deciding to cancel. So I think that's a challenge. And then right now, I just got a question from our partner, earlier today, asking if we could get, what's the second cMAb? Is Ganabab? Anyway, there's some, I think, some supply chain issues that we're running into today that we've got to figure out. That I'd rather.
Are you talking about single agent etesevimab ordering to pair with single agent bamlanivimab inventory?
Correct. Yeah. So we just got that question. The state isn't providing that for us, so they're asking if we can obtain that, and I don't know the answer to that. So, I mean, that's a question that came in today, but our sort of two biggest challenges are, can we get that drug, and patients are canceling prior to their infusion.
Okay. Great question. We pause on that. Dr. Chuk, don't mean to put you on the spot here, but in talking with Lilly earlier in the week, or last week rather, when a lot of this was sort of unfolding, a spokesperson at Lilly had indicated that HHS acknowledged the value in allowing for single agent etesevimab ordering to pair with any remaining inventory of single agent bamlanivimab. Are you at liberty to comment on the possibility of direct ordering for single agent Eddie?
Sure, absolutely. And that's actually been available for several weeks. Sites who are able, and again, all sites are now are able to order directly from the distributor AmerisourceBergen. And they are able to order single agent etesevimab to pair with bamlanivimab that they have on hand. And that has to go through the SmartSheet ordering system. Be happy to put, and actually, Sarah, if you want to put the link to that. And the only reason it has to go through that system, some of the other clients are actually ordering through ABC's normal commercial ordering. But because the single agent etesevimab has to be paired with the bamlanivimab on hand, we just have sites do a simple attestation to say, yes, I actually do have enough bamlanivimab on hand to provide this, and that they will administer the two drugs together as authorized by the emergency use authorization from FDA. So it's just a simple checkbox that they have to do, but absolutely the etesevimab is available. And we don't encourage sites who have a lot of bamlanivimab on hand and are not using that to infuse patients simply to order the etesevimab to pair up, but absolutely for sites that are actively infusing patients and wish to pair, that is the reason to be doing that. So there are some order limitations on the number of doses of patient courses of etesevimab, but again, that's only to ensure that sites are actually able to administer that. So that is currently available, and please let me know if there's any problems with that, because that has been several weeks.
Great. Thank you, Dr. Chuk. And Gina, before I hand it over to you, I'll provide a little bit of color and context for the audience here. As we're throwing around a lot of jargon, a lot of drug names they may not be familiar with. So Eli Lilly was the first company to receive EUA for the first cMAb product, which was bamlanivimab, single agent bamlanivimab, that has since sort of converted to a combination therapy of bamlanivimab and etesevimab, both assets brought to market by Eli Lilly under an emergency use authorization. Now, due to the prevalence of a viral variant dubbed the California variant that is not susceptible to single agent bamlanivimab, the FDA decided to no longer allow ordering of single agent bamlanivimab, initially in 3 states, specifically California, Arizona, and Nevada, with this variant representing 52%, 25%, and 41% of cases in those states, respectively. As of March 24th, due to an increasingly high rate of variant infections, the FDA decided to halt distribution of all single agent bamlanivimab across all states. However, according to a Lilly spokesperson, preclinical data demonstrate that the combination of bamlanivimab and etesevimab maintains its neutralizing effect against the California variant specifically. And now, as Dr. Chuk hammered on, any sites that have small inventory of single agent bamlanivimab remaining may order single agent etesevimab to pair with bamlanivimab for continued treatment. Gina?
Hi.
Existing problems you're still encountering?
So ours is a unique situation where we went in as a federal disaster response team. Those were our providers that went in to establish this pop-up that was adjacent to El Centro in their parking lot. We were a separate entity from them, so the patients were not seen in the hospital ER. So they were seen in our tent and treated in our tent. So when we transitioned over, what happened after 20 days, we transitioned over to the hospital and they continued to carry out the treatments within a tent or within their ER tent in the hospital. So I can't answer questions as far as like after we left onto the volumes and their processes or their challenges. But again, ours was mostly due to we felt that we could have a much higher volume coming in than what we did. El Centro did take a lot of action with doing PR and reaching out to the community on our behalf when we established the site, and that's how we got the walk-ins. And then they continued it on. They used Facebook and social media a lot and had live Facebook sessions, actually when we were first there, to be able to spread the word as well. And I know that they are successfully continuing infusions, not at the volume that we were, but again, a lot of it is because of the number of those testing positive were not as high as when we were there. When we were there, it was the highest California had seen. Their entire hospital was filled with COVID patients, and their non-COVID patients were treated outside in adjacent medical tents. So it was just, it's a different time for them, but it is still ongoing.
Okay.
Thank you, Gina. I do see a question in the Q&A box as well related to El Centro that I can answer. And it was about insurance plans billed. So we were a federal entity and we provided our own supplies. First 24 hours, we were short a couple of our supplies because they hadn't come in. So El Centro gave us their supplies, but then we replaced them. So when someone came into us, we were using federal resources and federal supplies. So there was no billing and registration for billing whatsoever. The antibody, the monoclonals were provided, as well as our federal team resources supplying the tubings and such. So there was absolutely no cost that occurred to the hospital at that time.
Thank you, Gina. And I see that Sarah had posted a link to the direct ordering workflow for single agent etesevimab. We've also included a link to the general direct ordering workflow for cMAbs in the resources page, and we'll share the slide deck with all participants at the end of the webinar. Shannon, biggest current challenge you're still encountering?
Sure. Our biggest challenge right now is ensuring that the team still keep up with infection control protocols and procedures. As more things open up and now that the mask mandates have been removed, it's imperative that our team still utilize MPP protocols, CDC, and the state health guidelines and procedures to ensure that the retransmission doesn't occur and patients get sick all over again.
Great. Thanks, Shannon. So a point that Woody mentioned is sort of increasing declination rates. This is a trend that we've sort of seen throughout integration of cMAbs since the first cMAb asset became available under EUA. There's a trend where patients are declining therapy in between symptom peaks. So after that first peak of symptoms, they're starting to feel better and they're declining treatment. And many of those patients, after the emergence of a second peak of symptoms, come back and want the therapy, but at that point they've surpassed that 10-day eligibility window and they're no longer eligible to receive the treatment. So it's something that we can address through increased education at the PCP level pre chair, between the script and chair, essentially. Okay, got some more questions here. One question is trying to identify the most common ADR or adverse drug reaction that's been seen during and after treatment. Anybody want to comment on some of the reactions that they've seen either during or post administration? Other than general symptoms, I would imagine.
This is Gina. I can speak to, so we saw, we infused 175 patients at our site, and we had one person whose O2 sat drops a small amount, but it was bordering when they came in, so we transferred them over to the ER. Other than that, we did not see any adverse reactions out of the infusions that we administered there during the time that we were there. I will tell you that before we arrived, the hospital had started a few infusions, and they were giving, they were pre-medicating with Benadryl and Tylenol. It was their understanding that it was required in the EUA, and we confirmed with them that it was not required in the EUA, and we stopped that process once we started up our pop-up tents in that mission. So the no adverse reactions were without pre-medication. We did not use pre-medication at all.
Great, important distinction. Thank you, Gina. Other panelists, did y'all encounter any adverse reactions, any infusion reactions in your CMAB sites?
I think out of the 600 plus patients that we saw, there was about 3 that got itchy. We just utilized our standard protocols that we would get from, like, we would use in a normal biologic situation, you know, using Solu-Medrol or Benadryl. We did not pre-medicate patients, but if they got into a situation where we felt like we needed to give them something, we would.
Okay, thank you. Woody, anything to add?
I don't. I'm not clinical, so I'm not super.
Okay. In speaking with Jordan, we didn't uncover any infusion reactions within the workflow. Okay, so Gina, on the topic of O2 sat, another question came in about vital monitoring. Wondering if vital signs were monitored for patients receiving CMABs on a continual basis, or at certain intervals during treatments, outside of obviously establishing baseline?
Sure, thanks for that question, Brian. So we were in an open tent, as you might have seen in the diagram in a previous slide. So everyone was totally visible to the caregivers. We could do that because they were all positive COVID, and we didn't have anyone that was not positive in that tent. No visitors, no ancillary staff, anyone that was not in full PPE or was positive. Those were the only individuals in there, so we could do that. We did take a set of vitals when they first arrived, and that was part of their brief history or medical history that we took when they came in the door. And then we monitored them, and just by visual, you know, if we saw someone that looked like they might have had rapid respirations, then we would go over and put the pulse ox on them. The second set of vitals were prior to when they left, and that's when we would give them discharge instructions and how to follow up as well. I do know there were some sites that were, our site was the first federal site that had opened in California, and there were 2 others that opened shortly after that. They, their perception of the EUA and the sites that they were working with had actually, some had patients on monitors because they saw the word monitor in the EUA. And then we had others that were taking vital signs every 15 to 20 minutes during the infusion. We went back again, reviewed the EUA, it wasn't required. So we stayed with our practice of taking them at the beginning and taking them at the end. And if anyone had developed any symptoms or raised any concerns, we certainly would have checked them again during that time.
Great, thank you. Shannon, Woody, anything to add there?
We did the same thing. We had a nurse practitioner assess the patient when they came in, just to make sure that they didn't need additional oxygen or anything like that, which would take them off the ability to get the monoclonal antibodies. But other than that, we just monitor them like a normal biologic patient. We did it every hour. We did it after the infusion. If they had if for any reason they had to be observed, then we would do it during then, but we would just do an assessment in the beginning with their vitals at the end, and then anytime that the nurse practitioners or the nurses felt like they needed to.
Great. Woody, any deviation from NICA standards as it relates to vital monitoring?
I'm not super familiar with our policies there.
Okay. For our discussions with Jordan, it didn't sound like you guys had any specialized protocol outside of NICA standards. Okay, great. So there was a question that came in about if any of your models have partnered with large testing sites like CVS or Walgreens. So talk about, I guess, your referral volume and if your main referral sources were tied into a testing workflow.
I can start. Unfortunately, we were not connected with testing. It was just the community around us, the small clinics around us. We tried to get word of mouth to them. There was a testing center within a half mile of us that was a walk-in testing center, but we were unable to connect with them to get them to do their referrals to us.
Okay. I know this has been a really big challenge. Sorry, go ahead.
Sorry, we did not partner with CVS or Walgreens. It was a lot of word of mouth by the big hospitals and the PCPs around in the area.
Yep. Woody, do you know if the primary care group y'all partnered with had sort of a testing workflow or primarily relying on just community referrals?
It was just community referrals, just some relationships with local hospitals.
Okay.
I would just like to say, I think that's a really critical point in that sort of patient journey. And we've been partnering at the HHS level with a number of large testing companies to try and have them put information, and have been successful in doing so on a number of positive reports or patient portals or on their website, at least linking back to the Combat COVID website, which has information on both the HHS and the NICA locator. And information to talk to their providers. So that really is a critical point. And certainly if there are infusion centers within particular communities, really getting those associations with the testing labs, I think is a really critical part. Great point.
Great. Thank you for HHS's work on that piece. As we've uncovered, patient education at the point of positive test results is pretty critical. Really just reduce attrition, help make sure we're steering the right patients, eligible patients, into the treatment workflow. Okay. Transition. Sorry, a lot of chat boxes and Q&A boxes here to try and comb through. So another concern expressed by these participants that completed our survey relates to an inconsistent referral stream, as primary care docs didn't appear to embrace mAbs and have positioned to focus exclusively on vaccine adoption. Love to get our panelists' thoughts on this and any challenges they've encountered with consistent referral streams, as we've seen a shift in PCP focus from reactive treatment with mAbs to prophylactic treatment with vaccine.
We used time when our patients, when their infusions were done, or even while they were infusing in their observation, we had lots of conversations with them. to help them pass the time. And we often encourage them to spread the word that we were there and that these infusions are available if people are eligible. We had some of the, towards the end, there were little flyers that were handed out that people could either bring to their family member or back to the primary care's office. Our success truly at that point was, this was very new, for everyone across the country, and it was really word of mouth. We actually had a provider who came in very hesitant. His wife was a nurse and was insisting that he come in for an infusion. He came in, he had mild to moderate symptoms. He had history of headaches, so he said his headache was really just, that wasn't anything unusual for him. And he had some respiratory problems, and these were just a little bit worse. He came in, he was positive. He came in and was infused, said he felt better shortly after he left. And so again, we just had conversation with him saying, please pass the word. Now you can go back and bring this into your practice. We hope we'll give you any of our brochure, the little posters that we've made. And the next day we actually saw 4 of his patients that were referred to him. And he just did it through televisits and made sure that his practice knew that this was available. So he was like one of our greatest salespersons for what we were doing.
Great. Thank you for that. Anybody else want to contribute to that?
We do have patients reaching out to us still asking us questions about the vaccine and these. Can they be taken together? How does this work? We're still following criteria. So as long as they're meeting criteria, even if they have the vaccine, if they're popping positive, then we still will give them the antibodies, and we are actually encouraging them to not stop it. If they still are positive, whether they have symptoms or not, to go ahead and get it. It's not going to hurt. If anything, it'll make them better. I try to educate patients that we really are just trying to keep you out of the hospital. This is not a cure, but we're trying to keep you out of the hospital.
Thanks, Shannon. So kind of an extension of that concept, there was a question in here seeking guidance on the use of mAbs for patients who become COVID positive following their first dose of vaccine before their second dose. We'll follow up offline with responses, guidance, and links to related resources in that regard. There was also a question that came in, I think probably better addressed live as opposed to in written follow-up. And it relates to the disinfection, decon protocols, roughly infection control protocol and engineering controls that were put into place. Essentially, what were the models doing to disinfect the space to mitigate cross-contamination concerns for sites that were co-managing positive and non-positive patients in the same setting, not at the same time, but in the same setting. So Shannon, I guess that question's specifically for you.
Sure. So we hired companies to come in and do a whole terminal clean after every COVID day. Also, our teams would wipe down everything in between patients. Anything and everything that the team or the patients touched were wiped down. And then, like I said, we would do a terminal clean at the end of every COVID day, is what we called it.
Great. Thank you. So panelists or HHS, anybody, what would you say to infusion providers who, after hearing some of these discussion points, seeing predictive analytics, understanding that there is ongoing demand, that mAbs have a role, at least as use in concert with vaccine, what would you say to these infusion operators that are still reluctant to onboard and administer mAbs?
Yeah, I might just chime in. on this one. We offered the mAbs not because it's core to our business or our strategy, but we consider ourselves leaders in infusion therapy. And if you're going to be a leader, you have to lead. And if you want to be, a leader in healthcare, you've got to be a good partner, even when it's not sort of core to what you're doing over the long term. So we thought of this as a duty to who we are. It's just a duty. It's what we're here to help people. And our team is so excited to be offering these infusions. So while it doesn't meaningfully change our bottom line, it has been such a morale booster for the company, for the employees, because this is what most of the people in your organization go to work trying to do every day, and you get to save lives and be a good partner in your community. So I think if you can find a way to limit some of these challenges, there's just a ton of benefits to the community, to your company, to the employees, and just to the world, at large. So make it happen, and step up and do your part to help sort of stop this pandemic.
Thanks, Woody.
I would absolutely agree with your statements, Woody. I think that I deployed with 7 of my peers, who many of them had left their home states after several months of working either in an ICU or seeing very sick patients from COVID and dealing with death and a lot of those challenges. And they were refreshed to be able to see that they could do this treatment ahead of time and hopefully prevent some of those hospitalizations. The patients that we came in would state that they felt that it gave them hope. And we did the most basic lean project that you could do. We repurposed equipment that was there in the hospital. We repurposed a tent that they had used for another project that they were working on. So the expenses would have been kept down to a minimum. It was very simple. What we did was simple but safe and productive. So I think that sometimes people see all the requirements or they see the EUAs and they think, oh my God, this is a really big undertaking. How are we going to do this? And I think that if you just take a pause and look at it, it can be done in a very lean process and be very effective. And it doesn't have to even be in high numbers. We had 8 beds, but I know that some places have 1 or 2. I talked to a physician or someone last week that was on a call that actually did it all himself in his urgent care center. He had 1 exam room that he kept to be able to give the infusions, and he would schedule 1 or 2 a day. He would start the line, he would hang the infusion to make that difference.
Thanks. Shannon, anything to add?
No, I would 100% agree. I think that people are scared to give these because of COVID positive patients. When they hear COVID positive patients, these patients are patients like any other patient, and they need to be helped just like anybody else does. And so I think that's the word that needs to be brought out to people, is that, these patients are scared. They're told by their doctors to, they have COVID and sorry, we don't know how to help you. Well, we need to educate these offices on how to help these patients.
Yeah, that's a great point. Amidst a healthcare industry that's really been established as a sickness service industry, infusion operations are a little bit of an anomaly in the sense that they focus on wellness maintenance, right? Once your patients have achieved that state of clinical stability with a medical benefit drug, your teams keep those patients in a state of clinical stability, not necessarily used to treating infectious patients with significant viral load and disease burden and things of that effect. But I think one thing that's been clear and we've uncovered throughout this endeavor to onboard and integrate mAbs and expand the nation's access footprint is that it's difficult to operationalize monoclonal antibodies by setting up new infusion capacity. And what's clear is that at this point, we're really reliant on the nation's expert infusion operators to help us further expand the access footprint for these particular products. You all are the experts at putting drug in patients safely, consistently, with high quality care. That's exactly what we need in the context of these particular therapeutics. Some of the barriers in terms of what type of infection control needs to be implemented and engineering controls, things of that effect, we're actively working with the CDC to compile relevant guidance into a single sort of toolkit vehicle. But those aren't as significant a barrier as most have perceived them to be. And we've got 3 examples of where a very successful model was quickly and efficiently stood up with minimal infrastructure, but they've done so with consistent high quality medication preparation at front of mind, and they're furnishing those drugs consistently in a safe environment. So we know, virtually each and every one of you on the call would be able to safely and efficiently integrate these products as well. So in wrapping up, mAbs, again, represent a critical tool in minimizing the burden of disease until individuals develop natural protection through passive exposure and recovery or through vaccination. With new variants arising across the globe and scientists fearing that future mutations in coronaviruses may lead to new strains that make the leap from animal hosts to humans, we must prepare for a new normal in which reactive therapies for COVID-positive patients are used in concert with prophylactic vaccine. To minimize the evolving burdens of COVID-19 disease, we need to leverage predictive analytics and the nation's infusion providers to expand access to mAb infusions across a diversity of safe care models. There is significant motivation in identifying and reducing perceived barriers to mAb operationalization across the nation's infusion experts. We hope that you've found this webinar to be informative and that you are leaving with a better understanding of the common headwinds and ways that you can address them to expand infusion capacity for mAbs with your current operations. We've got some resources here. If you're currently or willing to offer mAbs, please visit covid.infusioncenter.org to claim and build your infusion center's profile. For general information, visit the HHS COVID-19 Information Hub at combatcovid.hhs.gov. For prescriber, patient, or provider resources, visit NICA's mAb Resources Center. If your operations are prepared to furnish mAbs immediately, you may begin the direct ordering process by clicking on that link we've included. And finally, if you'd like to connect with us to explore how to make this work for your particular practice, please email us at covid19@infusioncenter.org. Thank you again for attending today's webinar and for your ongoing commitment to providing safe environments for consistent high quality care. And thank you to all our panelists for joining us today. Thank you all. Stay well.